Hi guys, in this video we are going to be having a discussion of the questions from the subject of pathology which were given in your FMGE July 25 exam. Now, the good point about this particular paper was that one, the subject of pathology was humongous. I mean, if you just look at the number of questions which were asked in the paper 1 and the paper 2, so many messages of satisfied students who recalled the mission classes, who recalled the quick revision videos, who recalled the main videos at any point of time that they had watched, and they were so very happy that they could manage to crack the questions. The second point that I wish to emphasize over here is that majority of the questions which were asked in this particular exam were fairly easy. Now, the number of questions which were considered as slightly difficult by the students were also manageable, except one or two questions about which I'm going to be having a special discussion with you. So, as the image shows you over here, it was a very appropriate example of the right synergy that you have of your brain applying in your mind and your heart going in the right direction to help you crack that questions. There were almost 30 plus questions that I got, and of course, there were so many additional overlap questions that we have talked about in the main Mission Live classes. So let's get started over the discussion straight away. Looking at the first question, it made the mention of a 45-year-old man who was having the presence of a chronic heartburn and retrosternal discomfort for several years. Upper GI endoscopy revealed salmon-colored velvety mucosa in the lower esophagus. Very, very classical description of a patient having gastroesophageal reflux disease. Endoscopy showing you the presence of a salmon-colored velvety mucosa. In fact, the good point about this question was this was also given as the point in the question. That means that already mentioned the diagnosis for you. So the only thing that was asked in the exam is the type of the nature of the epithelium which is going to be changing over here. I mean the type of metaplasia that is going to be observed over here. I don't think there can ever be a more easy peasy, or I would say a laddu question beyond this one. So that is going to be a transition from the squamous epithelium to the intestinal type of columnar epithelium. We discussed the fact, and that is just for a quick recap, that this particular epithelium is going to be having the presence of goblet secreting cells which can be picked up with the help of a dye like alcium blue, and that alcium blue is actually responsible for staining of the acetic mucin, by which you can demonstrate the presence of the goblet cells. Why do we talk about the salmon colored velvety mucosa over here? Is because of the simple reason that this condition predisposes your patient for development of carcinoma of the esophagus, particularly in the lower part, and that too adenocarcinoma. So nothing more for over here for any further future question, but of course I would like to make a mention of a specific option given over here, which was the individuals who are going to be having transition to squamous epithelium. Now this can be a potential question which can talk about a patient who, as I discussed with you in the main Mission Live classes as well, is going to be coming because of the result of medical tourism from a place like Middle East. He is having the presence of, let's say, schistosoma infection or stones in the bladder, because of which there is a change in the nature of epithelium from urothelium or the transitional epithelium to the squamous epithelium, and then this patient is going to be at high risk of development of squamous cell carcinoma of the urinary bladder. So that is one of the questions that I foresee to be given in your exams at some time in the near future soon. And that was an example of an easy question. Let's proceed to the next one. This was an example of the discussion that we had, of course, reminding of the people who are going to be appearing in any subsequent exam that whenever we're going to be talking about the commonest example of epithelial metaplasia, do not mark it as Barrett's. It is to be answered as squamous metaplasia in the lungs of smokers. Commonest example of connective tissue metaplasia, as most of you are familiar, is a condition that is given the name of myositis ossificans. Talking about the next one, female patient who presented with the manifestations, which is iron deficiency anemia. She's having dysphagia and she's having glossitis. Now, this is exactly what we discussed when I was discussing with you the risk factors for development of esophageal carcinoma. Over there, we talked about an example of a condition that is given the name of Plummer-Vinson syndrome. So, this is typically a female who's going to be having esophageal webs. This explains the development of dysphagia. The patient is going to be having iron deficiency anemia, and she's always going to be having the presence of glossitis as well. So that makes the classical triad. Therefore, what we are going to be having over here as an answer for the question over here is going to be the Plummer-Vinson syndrome. Why do we talk about this condition? It enhances the risk of development of cancer in the upper part of the esophagus in your patient. What type of cancer? Of course, you know the answer, guys. Squamous cell carcinoma. Please also understand the fact that one potential question in the exam, which is obviously important over here, is achalasia cardia, the condition in which you are going to be having a smooth tapering, which was given in your last exam, having a Birdwick appearance, right? So that was because of the selective loss of inhibitory neurons. Then we are talking about dysphagia lusoria. Dysphagia lusoria, I wish to remember, is going to be esophageal compression, that is because of an aberrant vessel. applied a NAT path link over here. What vessel is going to be causing compression of the esophagus over here? So that's an aberrant subclavian vessel, because of which the patients are going to be having a dysphagia. Of course, carcinoma of the esophagus is something which most of you have a fairly good idea about. So the answer for this particular question is Plummer-Vinson syndrome, without any doubt, as what we had discussed so many times in our sessions. Looking at the next question, which of the following is a translocation that is seen in anaplastic lymphoma? If you are a guy who is going to be watching this video for the sake of questions for the NEET PG exam, this is the only question I want you to keep in mind, right? Because we had a discussion about anaplastic lymphoma with regards to the fact that point number one, it's an example of a T cell cancer. Fact number two, you are going to be having the presence of ALK gene mutation. Fact number three, you are going to be having characteristic cells which are going to be given the name of hallmark cells. Reminding you of the fact, hallmark cells are going to be having horseshoe nucleus, or they are going to be having the presence of the embryoid nucleus. Some things that I have already made a mention of in the live sessions as well. But what we did not anticipate, and I admit to that, what we did not anticipate was that in the screening exam, they would be asking a question on a translocation. अब एक दो questions तो यार इधर उधर चलते हैं, for the simple reason that nobody expects you to score a 300 on 300, whether you are reading from cerebellum or anywhere, right? So this is the question which was asking you about the translocation, and the translocation that is going to be seen in these patients is going to be typically translocation 2-5. Now, there's another way by which the question could have been cracked. As I've been telling you, sometimes if you just apply small tidbit of your mind and you have ample number of neurons, guys, never ever forget that, irrespective of whatever naysayers may say, translocation 1814 तो सबको पता था भाई, ये तो आपको पता ही है कि this is going to be Burkitt's lymphoma, right? So you remember the fact B can be converted into numerical 8. So wherever you're going to be having chromosome 8 being involved, I mean 814, for that matter 28, for that matter 822, that was a previous NEET question as well. All these three translocations are a feature of a patient who's going to be suffering from Burkitt's. So if I rule out 28, if I rule out 822, if I rule out 814, obviously by exclusion also I would be getting the answer. Nonetheless, from the perspective of a future question or for any other question, remember translocation 2-5 is what is going to be seen in a patient suffering from anaplastic lymphoma, without forgetting that the classical features over here are hallmark cells with the horseshoe nuclei or the embryoid nucleus, right? Talking about the next one. Now, this question had two versions which were shared by the students. One was elderly patient who was having the presence of a low-grade fever and lymph node enlargement for a long time. He undergoes evaluation, of course, and he was advised flow cytometry which showed presence of CD19, CD5 and CD23 plus cells. So, this would be a patient who is going to be suffering from a condition that is going to be given the name of small lymphocytic lymphoma, right? Why? Because small lymphocytic lymphoma is a kind of variant which is going to be causing predominant involvement of the lymph nodes. The hematological version of this cancer is what we have discussed, that is CLL. But the lymph node variant is what is going to be given the name of, or the lymphoma variant is given the name of SLL, right? The second variant which was given by a student was कि sir same question tha, elderly patient, but he was having the presence of fever, he was having the presence of certain abnormal atypical lymphocytes on his peripheral smear, and they ask you the flow cytometry pattern that is expected in this kind of a cancer. So it was a CLL patient and they expected you to talk about the flow cytometry pattern. Now, whatever way, I mean, you hold your ear like this or you turn it the other way around, bhai answer change nahi hoga. So, इस question के अंदर there is CD5 and CD23 positivity. CD5, as we understand, is a marker for normally T cells. CD23 is a marker for B cells. Here you have a cancer. Cancer has got a mutation, and because of the problem, there is going to be expression of CD5 and CD23 in the same patient. So, this is a patient who is suffering from a condition that is given the name of small lymphocytic lymphoma, right? Of course, the standard questions are what you're already aware of. What is the cell of origin over here? That's a naive B cell. Peripheral smear findings showing you smudge cells. Example of a cancer which is going to be seen more common in elderly patients, and the only example of a blood cancer not related with radiation exposure, right? So that is what is going to take care for discussion for this question. Looking at the next one. Now, this was a classical history that we had talked about in the mission classes. When I talked about, they would never ever give you sideroblastic anemia as direct question. भाई दो या तीन histories जो आपके साथ share किया था. First was a patient who's going to be having the presence of a side effect of a drug being given like isoniazid, right? If you remember that. The second one I told you was a patient who's going to be suffering from lead poisoning. Now, lead poisoning, I had shared with you two clinical situations. For those of you who had attended the mission live classes would be really smiling all the way through this question. One was an adult patient who was working in a lead paint factory. So because of the fact that he is having an occupational exposure to lead, he would be having a higher chance of development of lead poisoning. The second would be a situation wherein a child, right, because of sheer curiosity or otherwise behavioral issue, is going to be eating the paint flakes which are coming from the wall. So this is what is going to be responsible for causing higher chances of lead poisoning. So read the question. School going child evaluated for underperformance in the school and reduced hemoglobin levels. So obviously, if the child is having anemia, he's not going to be performing academically well in the school as well. So he has a history of eating wall paint for the past few weeks. So this wall paint quite likely is going to be associated with intake of lead by this child, and that would be responsible for causing lead poisoning, and that lead poisoning would have been associated with development of sideroblastic anemia. So fairly specific history, which is going to be matching with the description that we had, and that is what is going to be the answer for this question. However, this is not to be confused with the question that had been asked in one of the exams previously. In any age group, mind my words, in any age group, if you are talking about the commonest type of anemia, which is going to be responsible for causing microcytosis and hypochromia, the answer obviously is going to be nutritional deficiency associated iron deficiency anemia. But with a specific history of a child having an intake of wall paint, my preferred answer over here, of course, the answer of choice is going to be sideroblastic anemia. Just make sure that if you are going to be appearing in any exam subsequently, you understand that particular table that we always make a mention of in the iron profile, along with the 4 important causes and the clinical histories that I've shared with you earlier as well, right? So again, an example of an applied question, but as I know, you are intelligent people, so you've answered it correctly. The next one talks about a patient expired as he has accidentally suffered from an unknown gas poisoning. He has cherry red appearance of his blood at his PM finding, and which of the following is the likely cause. Now, over that question, I will talk about, that's usually the first thing I start off with in the video when we talk about the topic of cell injury. So we talk about something called as hypoxia being the commonest cause of cell injury, and we talk about the various subtypes of hypoxia. Now, one of the important subtypes of hypoxia, as we understand, is anemic hypoxia, in which there is reduced oxyhemoglobin concentration. Why would you have anemic hypoxia? One of the classical examples, as I shared with you in the video as well, is carbon monoxide poisoning. Pretty well going with the fact the patient is having a PM appearance in which the blood is going to be having a cherry red appearance. So this is going to be an example of anemic hypoxia. No doubt to that. And there were so many other questions which were having overlap with path and, let's say, pharma, path and medicine, path and micro. And I believe that once you've attended the mission class as well, you would have been having a very easy peasy way of answering those questions, right? Then talking about a question which is making a mention of a 22-year-old woman presenting in the emergency department. She had high grade fever, she had diffuse erythematous rash, she had hypotension and shock. She started menstruating 3 days ago and reports using super absorbent tampon. This is a classical history of a reproductive age group female having the presence of menstrual cycle, because of which she is going to be using a sanitary tampon in the improper way. And this is going to be responsible for causing proliferation of staphylococcus bacteria in her genitalia. The staphylococcus is responsible for the secretion of a toxin, because of which she is going to be having the manifestations associated with the release of super antigen. If you remember, I talked about the concept of activation or interaction between the APCs and the T cells. And in case of a situation when we talk about a super antigen, we had a discussion that the antigen is going to be lying outside over here and is responsible for causing massive release of cytokines, thereby responsible for causing the toxic shock syndrome, right? So this is an example of a classical description that we had a discussion about. Super antigen like TSST1, toxic shock syndrome toxin 1, responsible for the manifestations in which patients will be having high grade fever, she's going to be having hypotension, she's going to be having a rash as well. And that is going to be a very classical history that you have to keep in your mind from the perspective of the exam question in the future as well. The next one is a patient of road traffic accident was brought to the hospital emergency when he was given 4 units of packed RBCs in the first 2 to 4 hours. Large volume of blood being given in a shorter span of time. That's a crux that we had talked about. The problem that is going to be encountered over here is going to be that you are going to be having too much of blood component that is being given. Blood component is going to be having the presence of an anticoagulant substance that is going to be given the name of citrate, something that we had in a discussion. This citrate is responsible for causing development of hypocalcemia, and that is responsible for metabolic alkalosis as well as the perioral paresthesia that is going to be observed in the patient. So the question was fairly simple, that he asked you what is the type of electrolyte disturbance that is going to be seen in this patient. Of course, the patients are going to be having the presence of hypocalcemia, because of which there is going to be a development of metabolic alkalosis, and the patients are also going to be having the development of the paresthesia as well. Please be familiar with the fact. The other important problem that can be seen with a large unit of transfusion being done in a short span of time classically is going to be hypothermia. So that was a previous exam question, and this one they asked a straight question about citrate being going in her blood and is responsible for causing development of hypocalcemia, right? So that is, I hope, an easy question that most of you had fairly easy, way through in the exam. The next was what brought a smile on the faces of a lot of people. I mean, something which is actually based on the mnemonics or the acronyms that we have been talking about. Example of a pro-apoptotic factor. So you had a discussion about the fact there are certain factors which are going to be responsible for increasing apoptosis. Some factors are responsible for reducing apoptosis, and some are going to be given the name of sensors or initiators. Of course, whenever we're going to be talking about BCL2, BCLXL, MCL, all are going to be having alphabet L. Not to forget, love steroids or sex steroids, they are also going to be anti-apoptotic in nature. So, of course, by that particular point, I can straight away rule out something like MCL, I can rule out BCL2, I can rule out BCLXL. Therefore, I would get the answer of choice, and that is going to be BAX. Of course, we are familiar that P53, BAX and BAX straight away as an information as what we had discussed over here and in the live classes as well, apart from glucocorticoids, are pro-apoptotic factors. So they are responsible for stimulation of apoptosis. I mean, so many times a discussion about the stepladder pattern, the chromatin condensation, the efferocytosis, you have it on your tips by now. Just keep in mind, any question which has been often asked in the exam should not be marked incorrect just because of lack of revision. This is a very simple advice I'm sharing with those of you who are going to be appearing in a subsequent exam. Listen to the classes carefully. The notes sometimes appear very condensed to you. I mean, people have a feeling, sir, 100 पेज आपने दे दिए, उससे क्या sufficient हो जाएगा? But those 100 pages actually is a gold mine of data for the questions that are being asked in the exam, right? Talking about the next one, middle-aged patient with change in her voice, anemia, recent hair loss, and cold intolerance has been diagnosed with Hashimoto's. I mean, this was a very unique feature of exam. This time around, they made things fairly easy for you. I mean, whether we are talking about the Barrett's esophagus question or I'm talking about the Hashimoto's question, I mean, he made a diagnosis. Now, what more can you expect? I mean, examiners are so friendly these days, I would say, or maybe for this particular exam. And he's asking about the antibody that is going to be seen in these patients. So, Hashimoto's, of course, is an example of a condition that you associate with HLA-DR3, DR5, potential question, is associated with the patients having the presence of a anti-thyroid peroxidase antibody, which is going to be the classical feature of this particular condition. TPO is an enzyme very critical for the formation of T3 and T4. That's a physiolink that you need to understand. So if I block this particular enzyme, T3, T4 levels go down. That explains the development of features of hypothyroidism in my patient, right? So fairly easy question, I would say, and that is what we had a discussion of in the main videos and in the mission classes as well. The next one I talk about is a 30-year-old man having a development of fever, chills, back pain, and hemoglobinuria within 1 hour of receiving a blood transfusion. The transfusion is immediately stopped. The lab investigations reveals elevated serum LDH. Now, presence of a manifestation like fever, chills, back pain, and hemoglobinuria is very much suggestive of some kind of a intravascular hemolysis taking place in the patient. On top of it, the question mentions serum LDH level is elevated. So, my patient is having the presence of hemoglobinuria. He is having the presence of a back pain, which can be explained on the basis of hemoglobin being released and then getting deposited in the kidney and then causing damage over there. And my patient is having increase in serum LDH. So all these are pointers that my patient has suffered from a hemolytic reaction. Now this hemolytic reaction has taken place within first hour. So I would be calling it obviously as an example of a acute hemolytic reaction. And this kind of an acute hemolytic reaction obviously is going to be seen because of the commonest reason being that there has been unfortunately a mismatching of the blood which has been given to a particular individual, right? So mismatched blood transfusion reaction. We discussed the fact as well as the important thing over here that why do such reactions occur, primarily because of a clerical error in which a wrong kind of a sticker is being unfortunately pasted on the blood bag. Now this is an antibody mediated hemolytic reaction, so of course this is an example of a type 2 hypersensitivity reaction. The age-old mnemonic, the mnemonic that we created almost like 16 years back, coming to your rescue time and again, not only for this question, but for another question that was asked in the exam, which was a myasthenia gravis question I'm going to be talking about subsequently. So as we discussed, that was the type 2 hypersensitivity reaction with the classical history which was given in this particular question. So I hope an easy question that you were able to mark correctly. The next one talked about a middle-aged female with bilateral ptosis and muscle weakness getting worse by evening undergoes the CT scan of the chest which shows presence of a thymoma. Now, two places where we talked about this kind of a discussion when I was sharing certain clinical features of type 2 hypersensitivity reactions as I showed you for this particular discussion. So over there, we had a discussion about a condition in which patients are going to be having typically the evening presentation. So there is a variation in the muscle strength. Evening, the patient is a female patient. She comes to your office and she tells you, doc, I'm having the development of drooping of the eyelids or ptosis. She is unable to climb the stairs, again, particularly at the time of evening. So there is a variation. Early morning, she is relatively fine. In the evening, she is going to be having muscle weakness. And on top of it, the question makes a mention that CT scan showing you presence of a thymoma. Almost a confirmatory thing that we had a discussion about in our discussion of the paraneoplastic syndrome topic as well, that whenever we're going to be talking about thymoma, it is going to be associated with development of myasthenia gravis. Now you understand really well, myasthenia is an example of a post-synaptic problem for the simple reason patients are having antibodies produced against the nicotinic M subtype of acetylcholine receptor. We in fact had a discussion that a condition in which there is going to be a muscle weakness because of antibodies against presynaptic calcium channels is given the name of, as is mentioned over here, Lambert-Eaton syndrome, which is seen in a patient suffering from the small cell lung cancer. So the differentiation was pretty clear. You just had to apply your minds thinking about ptosis, muscle weakness, and patient having a thymoma. So I would be very comfortably making a diagnosis of myasthenia over here. Once I'm done with the diagnosis of myasthenia, of course, the next thing which comes to my mind is what is the fundamental problem in a patient having myasthenia gravis. So my patient is going to be having the development of antibodies against the postsynaptic acetylcholine receptor, right? So that was where the trouble was. In fact, we did talk about the treatment for this condition as well. Of course, an easy question that you're aware by now, neostage mean plus atropine, right? Looking at the next question, a tall, thin male with disproportionately long limbs, arm span greater than height, and hyperextensible joint presents with complaints of progressive visual blurring. On examination, he has a lens which is displayed upward and outward. Echocardiography shows dilatation of the aortic groove. Classical description of a tall guy who is going to be having the presence of hyperextensible joints is having the presence of a lens dislocation, typically temporal and upward. This is nothing but a patient who's likely to be suffering from a condition called as Marfan syndrome. Now, we had a discussion about Marfan syndrome, guys, that this is an example of an autosomal dominant condition in which the fundamental problem in the patient is because of the FBN gene, and that is going to be responsible for causing a defect at the level of fibrillin 1. The other example or the options over here can be potential questions for your exam in the future, so just be very clear about them as well. If I'm talking about defect in collagen type 1, this is going to be seen as a feature of a patient suffering from osteogenesis imperfecta, again an autosomal dominant condition characterized by brittle bones as well as the presence of blue sclera. If I'm talking about a condition in which there is going to be a defect in elastin, this can be seen in a patient who's going to be suffering from a condition called as Williams syndrome. When we talk about Williams syndrome, remember hypercalcemia of infancy? Yeah, metastatic calcification, that is where we discussed it. If I'm talking about defect in collagen type 4, this is seen in a patient who's going to be suffering from a condition in which there is a kidney problem, there is an ear problem, there is an eye problem, and the condition is given the name of Alport syndrome. So for this particular question, the description was pretty clear. Tall guy, high arched palate, hyperextensible joints, arm is going to be more, having the presence of cardiovascular manifestations and lens dislocation. This is a case of Marfan syndrome and the patients are going to be having a defect in fibrillin 1. Talking about the next one. The presence of buccal mucosa melanosis and hematomatous polyp. I mean, this was a straight question in which they are talking about the presence of pigmentation. He's talking about the presence of a hematomatous polyp. When I write this combination, I automatically get the answer, and that is Peutz-Jeghers syndrome. So P for pigmentation, responsible for melanosis, pigmentation of the oral cavity mucosa, right? And there is presence of jejunal polyps, which is going to be an example of hematomatous polyp. We had a discussion, guys, that this was an example of a condition in which there is a problem at the level of STK11 gene mutation. Patients are always going to be having a higher risk for development of multiple cancers, including pancreatic cancer, including bowel cancer. Apart from that, what you need to remember is that this was an example of a condition in which patients were having the presence of, if I can just have the liberty of making that drawing for you, just helping you recall, that was a image based question for the NEET PG people as well. So there is going to be a branching or arborizing pattern that you're going to be getting over here, right? So that's a characteristic feature over here. The answer first, that's Peutz-Jeghers syndrome. Please have a look at the other options as well. Lynch syndrome is what is going to be given the name of HNPCC. This condition is going to be characterized by a defect at the level of the DNA repair. This is what is going to be having a problem at the level of MMR genes. That is going to be the mismatch repair genes are going to be defective, as a result of which the patients are going to be having in their cells microsatellite instability. Why would you read about Lynch syndrome? For two reasons. It enhances the risk of development of ascending colonic cancer in your patients. And fact number two, these patients are having not only the presence of colon cancer in females, that also enhances the risk of development of ovarian as well as endometrial cancer. So as I told you about the fact, if you don't work in a company, the CEO is actually going to lynch you, and that is what you just need to have an idea over here. When I'm talking about familial adenomatous polyposis, easy peasy one, this is what you are able to recall, is going to be characterized by chromosome 5q association, having the trouble at the level of APC gene. Patients are going to be having the development of adenomatous polyps. Minimum 100 adenomatous polyps are required for making a diagnosis of this kind of a condition. And we talk about three variants, the classical variant, the Gardner syndrome, as well as the Turcot syndrome. Whenever I'm going to be talking about the juvenile polyposis syndrome, a condition that is going to be seen in a child, it is going to be causing involvement of rectum. The child is going to be having a rectal bleed, And the problem that is going to be seen in this patient is going to be a problem at the level of SMAD4 gene, right? You were having the presence of a polyp in which you were having the presence of mucin-filled glands, and there is presence of infiltration in the lamina propria by the cells, right? So those were the additional things that you just need to have an idea for a quick recall as well as for a future question. Over here, the combination of melanosis and hematomatous polyp, of course, the answer can be nothing but Peutz-Jeghers syndrome. Talking about the next one, Mason in a stone factory in Kota, Rajasthan, presented to the clinic with dry cough and dyspnea. His chest X-ray demonstrated eggshell calcification. Now, two groups of people. One said that it was mentioned in the chest X-ray and the image was given and the question had a mention of eggshell calcification. The second group which said that this image was given. So obviously a very, very exact image about what we had discussed so many times earlier, wherein I told you the classically patient is going to be working in a construction site, or he's going to be working in a mine, or he's going to be working in a glass factory, and therefore he's going to be having an exposure to silica or quartz. So this is what is going to be responsible for causing, as made a mention of over here, so stone quarries, sand blasting, sand mining or construction, and there is going to be typically involvement of upper lobes. This is what is going to be classically seen as a feature of silicosis. So without any doubt, this is the commonest pneumoconiotic disorder about which you need to have an idea. Another question that was given in the exam was pertaining to the second type of pneumoconiotic disorder, in which they made a mention of a guy who was working in a cement factory. He was having shortness of breath and he was diagnosed with mesothelioma. So you remember the simple trick that we talked about, meso-specific associated with, as most of you are having a very clear concept and base. So whenever you're going to be having your base clear, that is going to be the basics start right from over here. So lower limbs involved, lower lung part of the lung is going to be affected in these patients, and this is mesothelioma, which is going to be associated with patients who are going to be having an exposure to something like asbestos, right? So fairly easy question, just reading about the keyword mesothelioma plus pneumoconiotic disorder, giving you the answer asbestos over here. In the previous question, the history of working in the sand mine and the presence of working in a stone quarry plus the presence of axial calcification going in favor of something like silicosis. Easy question, don't miss out on those questions in any exam whatsoever. Talking about the next one, this talked about a young male presenting to the emergency department after a road traffic accident, as he had sustained a fracture of the mid shaft of the right femur. After 72 hours, he has developed altered sensorium, shortness of breath, petechial rash up on the chest as well as on the conjunctiva. He had a saturation of about 85% and the chest X-ray showed you bilateral patchy infiltrate. A patient is having the fracture of long arm bones. He is having the presence of then CNS manifestations. He is having the presence of blood manifestations suggestive of rash, which can be explained by the development of thrombocytopenia, petechial rash. And the patient is also going to be having the presence of another manifestation, that is, he is going to be having the presence of shortness of breath and saturation is going down. So this is what is going to be immediately reminding you of what we had talked about earlier, involvement of blood, involvement of skin, involvement of the CNS. This fulfills the criteria that is given the name of GERD criteria, typically seen after a fracture of the long arm bones. So this is likely to be a case of a patient who's going to be suffering from fat embolism. Two very important things beyond fractures. For those of you appearing in a subsequent exam, beyond fractures, another place where you can be having a development of fat embolism, as I made a mention of over here as well, is patients who are going to be suffering from burn injury. Second fact is what we had talked about this as an image based question. They can talk about the fact that this guy could not survive, but on his autopsy, what we found was presence of clear vacuoles in the pulmonary vessels. So there is presence of fat emboli which are going to be entering inside the pulmonary vessels, and that is what is going to be seen as a very typical finding of a patient suffering from fat embolism. Right? Nowhere this could have been a case of air embolism, which we have talked about earlier, is going to be seen either in case of people going in for a deep sea dive or in case of people who are going to be, as medicos, you are going to be inserting that central line, and that is what is going to be causing the trouble, right? So very typical history, the timelines match, the description of the questions match, and the clinical features of the question all pointing in one direction, which is fat embolism. Talking about the next one. That question says, a chronic smoker develops cough and weight loss. His chest X-ray shows mass in the lungs, that's lungs, and biopsy shows chromogranin and synaptophysin positivity. Smoker who is having a lung mass which is having chromogranin and synaptophysin positivity could be a case of a patient who's going to be having a small cell cancer, a cancer which is also being known by the other important name of oat cell cancer, having a neuroendocrine origin. Why is it important? It contains lots and lots of neurosecretory granules. What's the importance of knowing about these granules? Fact number one, they contain a lot of hormone-like substances, because of which my patient is going to be having a very high risk of development of a condition like SIADH. Why exactly do we need to talk about small cell cancer? Is for a simple reason. Practically, it's an example of a cancer which is going to be highly aggressive. So therefore, having a very high chance of metastasizing to the brain, and associated practically with a poor prognosis. Just look at the other options in case they tweak a question in the subsequent exam. Hypercalcemia is going to be more commonly associated in a patient who is going to be suffering from squamous cell carcinoma. Of course, you know the trick over here. The PTH-rated peptide is the culprit. If I'm talking about gynecomastia, the tissues get large. So that's a feature of large cell cancer. Of course, remember the mnemonic as well. And if I'm talking about clubbing, more goes in favor of a patient who's going to be suffering from adenocarcinoma of the lung. So pretty straightforward question. History of smoking, chromogranin, synaptophysin positivity going in favor of something like SIADH. Beyond SIADH, you can be having another important paraneoplastic syndrome in these patients, and that is Cushing syndrome, right? Talking about the next one, it made a mention of an oncogenic virus like human papillomavirus is associated with increasing the risk or development of which of the following cancers. Now, this is an example of a virus which is going to be having two subtypes. So we are going to be having the presence of the low risk strains as well as we are going to be having the high risk strains. And what is this virus going to be doing? It is responsible for causing development of multiple types of cancers, as we made a mention of. The only thing which perhaps confused some people in the exam was the options which were as close as oral cancer and oropharyngeal cancer, right? So guys, we need to just recall the fact and listen to what is being taught in the class carefully. It's oropharyngeal cancer that is going to be associated with human papillomavirus infection. Please do remember the previous exam questions that low risk subtypes are responsible for development of two conditions. One, which is viral warts, and second, laryngeal papillomatosis. High risk subtypes are the ones which are responsible for causing cervical cancer, anal cancer. It is going to be responsible for causing oropharyngeal cancer and carcinoma of the penis. That is a must know information for all of you, right? So this was fairly easy question. I hope you got this one correct as usual. Talking about the next one, female undergoes a surgery for abdominal mass and pain for which shows the structure as given over here. I have nothing more to say. This was an example of a same image, because not of the fact that I agree with that question, for the simple reason that the source was common, and that's a very, very classical image in which they talk about the presence of an ovarian mass, which shows you the presence of structures like you can make out the presence of the tooth, you can make out the presence of the glistening mucin and fat, you can see the presence of hair, all pointing towards the fact that you're going to be having a tumor which is going to be having an origin from more than one germ cell layer. And we had a discussion about this particular fact that tumor is going to be given the name of a teratoma. Now, please understand the fact, what is the cell of origin of a teratoma? These are typically totipotent cells. Majority of the teratomas are going to be having their origin from the gonads. Two important features to be remembered. Teratoma in case of ovaries is typically benign unless proved otherwise. And this teratoma in the ovary is going to be given the name of, yes, you know that correctly, friends, that is what is going to be given the name of dermoid cyst. If I'm talking about a teratoma in case of a male, M for male, M for malignant, teratoma in male or the teratoma arising from the testicular tissue is going to be malignant unless proved otherwise. So in females it is typically benign, in males it is going to be typically malignant. That's a fairly important point that you need to remember. Because of the presence of origin from more than one germ cell layer, it is going to be having features like hair, having the presence of cartilage, fat, mucin, all that is going to be seen over here, which can be made out, and therefore an example of an easy question. Of course, the other important image which was given over here was about chocolate cyst. Chocolate cyst is a previous exam question which we talk about in case of patients who are going to be suffering from a condition called as endometriosis, right? So this was a fairly easy question which I presume that most of you had got correct in your exam. Talking about the next one, which is a likely diagnosis in a middle-aged patient with episodic headache, palpitations, and increasing 24-hour urinary levels of metanephrines. Episodic palpitations, headache, and the presence of something a patient is going to be having extreme sweating or diaphoresis, that is, which is going to be associated with a condition in which the patients are going to be having too much of catecholamine secretion, and that condition, as we have talked about, is given the name of Pheochromocytoma. Now, this being an example of an adrenal medullary tumor is going to be having more secretion of adrenaline and noradrenaline. Acted upon by the enzyme CUMT, it is going to be having the formation of metanephrines and the subsequent product that is going to be vanillyl mandelic acid. So, a fairly easy question when you're talking about the presence of PHNE, that is how we talked about it over there in the discussion as well, friends. Palpitations, you're going to be having the presence of headache and you're having the presence of episodic hypertension plus the presence of increased 24-hour urinary levels of metanephrines. You could not think of anything else but a patient who's going to be suffering from pheochromocytoma. So fairly easy question. I believe all of you got it correct in your exam as well. Talking about the next one. An elderly male presented with back pain, repeated infections, and serum protein electrophoresis showing you M spike. Elderly patient, backache, M spike. What more do you want for this? This is likely to be a patient suffering from a multiple myeloma. Now, what was the question over here? The question was asking about the prognostic factor. We had a discussion that one of the best prognostic factors, if the single best prognostic factor is to be taken, which can substitute the staging, right? So that is going to be serum beta 2 microglobulin. This is the second question which I want for those of you appearing for the NEET PG exams to be remembered. that apart from serum beta 2 microglobulin level, the other important protein which is going to be indicating the prognosis of a patient is going to be serum albumin levels. So the combination of serum beta 2 microglobulin and albumin is what is going to be determining the prognosis of the patient, right? In fact, this particular combination, if you just read your textbook of medicine, is making a mention that serum beta 2 microglobulin is the single most powerful predictor of survival and can substitute for staging. So this was the previous question. And when we are talking about something which is going to be given the name of ISS, the International Staging System, you have a combination of serum beta 2 microglobulin albumin level, which is going to be forming the basis of a classification because of which you can predict the survival. So that is what you have to keep in your mind as a potential future question. Of course, the standard questions making a mention of those grape-like cells called as Mott cells, having the presence of the M spike, what is the reason for the M spike, the electrophoresis pattern, all those questions are something that are very much anticipated, and multiple myeloma as usual is going to be a fairly important topic for your exams. Talking about the next one, a male patient had a fall following which he developed knee swelling. He underwent tests which reveals presence of increased APTT, normal bleeding time and normal PT. So there is an isolated problem at the level of APTT only. That too typically in case of a male individual with a history of fall. Now, won't that bring a smile to your face? I mean, you feel bad for the patient, of course, but the classical history that we have talked about, male individual having a history of fall, having the presence of joint swelling, suggesting of hematrosis, that means a clotting factor problem. And since you are having increase in APTT in a male patient, I would be thinking in terms of a condition that is going to be given the name of hemophilia. The commonest hemophilia for sure, as we understand, is hemophilia A, which is because of a problem at the level of clotting factor number 8, right? Of course, I can rule out the presence of von Willebrand disease, which is an example of the commonest inheritable bleeding disorder by the simple fact in case of von Willebrand disease, I would be having the presence of increase in APTT along with increase in the bleeding time. ITP don't stand a chance over here because that is not going to be altering the value of APTT. DIC is not going to be having this sweet presentation. It is going to be a classical case of surgery, trauma, obstetric cause, and then the patient's fibrinolytic pathway, the clotting factor, platelets, all going into haywire situation, right? So for this particular question, fairly easy. That is hemophilia A is what we wanted to be familiar with. Talking about the next one. Which of the following is a problem in a patient with Bernard-Soulier syndrome? You remember the tweak question that they asked you in the January exam? So in January exam, they asked you about the factor which is going to be interacting with von Willebrand factor, right? This time they asked you a direct question on Bernard-Soulier. So these are example of where we discussed about and made a mention of the qualitative disorders, not a problem with quantity of the platelets. It's a problem with the quality of the platelets. So there are two types of glycoproteins, if I may recall. I mean, this is what we have already discussed, where I talk about the problem at the level of either glycoprotein 1b. 1b means 1 over here. So that is going to be Bernard-Soulier. That's how you remember it. I mean, that's fairly easy recall for most of you. The problem we are going to be talking about, glycoprotein 2b, is a problem that is going to be given the name of Glanzmann's disease, right? So this is what you just need to have an idea. Glanzmann's disease, also given the name of Glanzmann's Myasthenia. And this is going to be fairly easy question. Therefore, Bernard-Soulier is going to be a problem at the level of glycoprotein 1b. Problem in von Willebrand factor is going to be an easy one. That's going to be responsible for causing von Willebrand disease. So nothing more to add over here. The only thing I want you to remember over here is 1b is Bernard-Soulier, 2b is Glanzmann's, and that is going to be a problem at the level of, if I may ask you that question, would it be a problem at the level of platelet adhesion or platelet aggregation? So you know the fact, Glanzmann's is a problem of platelet aggregation. And if I'm talking about Bernard-Soulier, that is the problem at the level of platelet adhesion. In case of anybody having confusion, I would request you to go back and watch the main videos, or for that matter, the quick revision videos, or please come to the live mission classes, understand these concepts. Fairly easy, fairly important, and they will help you get more marks. So as we always talk about the tagline, Mission 200 plus, you would be having an excellent score. You feel more confident when you appear in a subsequent USMLE or PG exam and you ace the exams like anything, right? Talking about the next one, this makes a mention of an elderly man presenting with progressive swelling of the legs and frothy urine. Elderly man, frothy urine, swelling of the legs. Physical examination shows bilateral pedal edema. Urine analysis shows 4+ proteinuria and fatty casts, all suggestive of patient having massive proteinuria and the presence of nephrotic syndrome. Now, the question was about the biopsies performed and Congo red staining reveals apple green birefringence under polarized light. That is where he just tweaked the question. So apparently, the first 3 lines made me think about, something good is coming my way, but then he just got a little bit sweeter. He gave you that renal biopsy shows you presence of apple green birefringence under polarized light. I mean, I don't need anything else to make a diagnosis for this condition, except I would be reminded of my basic concepts pertaining to Congo red, polarized light, apple green birefringence. This would all be going in favor of something like amyloidosis, extracellular deposition of misfolded proteins in amyloidosis. right? The other options are fairly important for a subsequent exam. So just have a look at them again, friends. Immune complex deposition due to membranous glomerulopathy. So this is typically going to be an example of a subepithelial immune complexes in membranous glomerulopathy. Remember, if I'm talking about mesangial involvement due to IgA deposition, that's a feature of a patient having IgA nephropathy or Buerger's disease. Remember the Buerger's we are talking about over here. So this one is without the U over here. This is BER, over here. Autoantibody mediated injury to the podocytes can be seen, because of which the patients are going to be having effacement of the podocytes. That can be seen in a lot of conditions, but the condition in which you are going to be having an auto antibody mediated injury to the podocytes because of cytokines as well is, especially in case of children, is going to be seen because of minimal change disease. In case of adults, that is because of focal segmental glomerulosclerosis. In case of elderly patients, that is because of membranous, right? So answer for this question over here is fairly easy. Amyloidosis having extracellular deposition, so that becomes the answer over here. Talking about the next one. A patient with high-grade fever, headache and altered sensorium undergoes CSF examination which reveals low glucose, high protein content and markedly increased polymorphonuclear leukocytes. Increased polymorphonuclear leukocytes simply means the fact that my patients are having increased number of neutrophils with the presence of low glucose levels. I don't think anybody requires any explanation for this. Too many neutrophils are suggestive of bacterial infections. You are having a lot of bacteria, they will consume glucose, so CSF glucose levels are obviously expected to go down. Because of the infection, there is going to be an exudate. This is going to be increasing intracranial tension. That is responsible for the clinical manifestations like fever, headache, and altered sensorium. So, what can you think of in this condition beyond acute bacterial meningitis? Recall the fact, if I would have been talking about a patient suffering from something like a tubercular meningitis, my patients are going to be having increase in the number of lymphocytes, as well as they are going to be having increase in the number of neutrophils, and that is given the name of CSF pleocytosis. What you got as a question for tubercular meningitis, if you make the CSF of these patients stand in a test tube, it would be having the presence of cobweb appearance because of protein settling down over here, right? If I'm talking about a patient having viral meningitis, I would be having the presence of increased number of lymphocytes over here, and the blood CSF glucose levels over here are going to be somewhat decreased or nearly normal. In comparison, bacteria are going to be having a faster consumption of glucose, so that's an easy thing that we just need to keep in mind. Right? Subrecurrent hemorrhage is going to be a totally different question. It would make a mention of a worst kind of a headache experienced by the patient, and the CSF is going to be having blood being appearing in it, right? So this was an easy question, acute bacterial meningitis. Talking about the next one, the question made a mention of a 19-year-old male presenting with complaints of infertility. On examination, he's tall and long limbs, sparse facial hair, gynecomastia, small firm testes, semen analysis shows azoospermia. Male individual who is going to be having azoospermia, who is going to be having tall limbs, having the presence of gynecomastia, and is having the presence of an issue, this is going to be suggestive of Klinefelter syndrome. So we had a discussion that even though this is an example of a tall guy, but just, physically the stature being tall doesn't help you anything. Your social stature, your knowledge is what is going to be making you far more important and shining brighter. So this is going to be a patient suffering from Klinefelter syndrome, and therefore we understand the fact that Klinefelter syndrome is going to be characterized by 47XXY. Nothing more to add for this question. This was a repeat question in different formats. They have given you this question. An example of a condition in which the typical description is being mentioned. And why do we talk about this condition? Because unfortunately, these patients are at higher risk for development of, that's a previous NEET question, by the way, higher risk for development of autoimmune disorders like SLE. And Klinefelter is a very, very important risk factor for development of male breast cancer. Mark my words, important question. Klinefelter is a risk factor for development of male breast cancer apart from the gonadal malignancy. Talking about the next one, 2-year-old newborn has upslanting palpebral fissures, having a flat facial profile and a single transverse line and hypotonia. Now, I do remember when you would have been watching this video, I did tell you about the fact that if you look at your hands even now, you are having multiple lines over there, at least 3 major ones that you have. But this individual is going to be having the presence of a single palmar crease with the description over here with a flat facial profile and the presence of upslanting palpebral fissures. This could be nothing but a patient who's going to be suffering from a condition called as Down syndrome. So fairly easy, about which we need to have an idea. Trisomy 21 is what you need to keep in mind, right? Talking about the next one. Now this was a slightly tricky question, but I do presume that you applied your minds over here. Skin graft was performed on a burns patient, which is so very commonly done. I mean, we talked about the concept of autograft, allograft, isograft, xenograft, right? I gave you certain examples. This was one example that we discussed. Shows sign of necrosis and slaying. And this happens after 4 days. Now, typically, when we are talking about any kind of a trouble at the level of the graft, you can be having an issue which is going to be given the name of graft rejection. Now, particularly with respect to renal transplant as a prototype, we talk about the presence of the transplant of the kidney being rejected on the OT table itself. Remember the description? The pink red kidney is going to turn black or cyanotic, right? So that is a typical immediate type of a rejection that is going to be seen because of preformed antibodies. What is the timeline given over here? 4 days. So graft is getting necrosed and slowed. That means it has been not taken up well. Now, why would the graft being rejected over here? So first thing that you need to understand over here is that this is going to be a case of graft rejection, right? So this is a case of graft rejection. Now, when I'm talking about the graft rejection over here, the timeline is coming very handy over here. It is taking place not within the first few minutes or first few hours. It is after 4 days. So if I may ask you a question, guys, is it hyperacute, acute or chronic? अभी ये तो आपको पता ही है. I mean, the moment we are talking about something which is going to be from days to weeks, it automatically comes into the category of acute rejection. Now, acute rejection can have two components. Either it can be because of antibodies, matlab acute humoral, or it can be because of cells. So that means there is involvement of T cells. Now, in context of skin graft, which of the two is you think is going to be playing a major role? It is typically the T cells which are going to be playing a more important role with respect to acute graft rejection in case of skin. So what we are having over here is that the graft is being rejected, and the reason is simply that the immune cells of the host T cells are going to be attacking the graft. So the problem over here is that the host T cells have attacked the graft, because of which the graft could not be taken up well. That's a case of graft failure, and this is what is going to be responsible for causing necrosis and slowing off of the graft, right? That is what you need to be familiar with for this question. A question of this type can also be asked in the exam in the future. So just be very clear about the concepts and the discussions that we have had in the quick revision as well as in the mission classes, and that is what is going to be making you far more confident, right? The next question that made a mention of a lady undergoing a pap smear examination at a camp for screening of cervical cancer. Of course, you are familiar that a better way of doing the screening is now VIA, as might have been told to you in PSM as well. Which of the following is a percentage of ethanol that is being used? So when we're talking about, the classical pap smear, we're talking about the transformation zone, we're talking about IR spatula, we're talking about the cytobrush, and we are obviously going to be talking about this percentage of ethanol, which is 95% ethanol. That is what we just need to keep in mind over here. So straightforward question asking about the fixative that is going to be used for pap smear. This pap smear is an example of, if you may recall, exfoliative cytology. You are taking out cells, fixing them, examining them, and then you're going to be doing the screening for the patients, right? So that is what you just need to have an idea. Talking about the next one, a patient has to undergo testing for prothrombin time and APTT. Which of the following vacutainers is most useful? I mean, prothrombin time and APTT means that you wish to check for the coagulation profile, and this is what we had talked about earlier as well, friends. Whenever you're going to be talking about either the platelet study or any kind of a coagulation study, the sample has to be taken in a vacutainer with a blue top. So the vacutainer which is going to be preferred for this kind of a condition is going to be a blue top vacutainer. Of course, that contains 3.2% trisodium citrate. I mean, this was what was known to you. But an example of a fairly easy question that I would just like you to recall. If I'm talking about the lavender color tube, that is for the routine counts, as we have made a mention of over here. So lavender is the one which contains EDTA for typically the complete blood counts, or for ESR by the Western method, a potential question for the exam. If I'm making a mention of the red color tube, it contains clot activator, typically for any kind of a serum estimations that you need to do. If I'm talking about the gray color tube, all-time favorite, you have a hold on this one, which is going to be containing the presence of potassium oxalate as well as the presence of sodium fluoride. Do not forget, and mark my words, do not forget the sequence in which these have to be drawn. So I hope you remember the fact that chalo bhai mnemonic. So chalo bhai, we just remember it. Culture is going to be the first thing, then the blue top vacutainer, then you are going to be looking at the red light. So it is red, yellow, green. Once it is green, nothing stops you. Let's go. You're going to be going out for cerebellum as well, as in when you're going to be sharing the good news of you clearing your exam with flying colors, of course. So that is what you just need to have an idea. Do look at this particular table. Again, if you're going to be appearing in any exam in the future, very, very high stuff that is to be remembered, right? Talking about the next one. This is again what I call as the easy peasy cheesy and a laddu question. I mean, best antibody for diagnosis of acute infection. I don't think that this was marked incorrectly by any one of you, right? So this was IgM, responsible for primary immune response, Millionaire's antibody, B cell receptor as well, and is going to be requiring for as a function for acute infection. So the answer is fairly easy. I don't think I need to explain this too much. That's fairly easy. But only thing I would like you to recall over here is fact number one, the different individual properties of different types of antibodies. That is very important. And of course, the relatively newer questions in case you are preparing for the NEET PG exam, that you are going to be having initial formation of IgM, subsequently you have formation of IgG. If I just help you recall, you initially have formation of IgM, then you will be having the secretion of antibodies like IgG, IgA or IgE. What is this phenomena called as? Change in the nature of antibodies being termed as antibody switching or isotype switching. That takes place because of a proper B and T cell interaction. You remember the CD40, CD40L story that we made. If this interaction doesn't take place, you would be having a condition that is given the name of hyper IgM syndrome. So At this stage, when you're looking at the question over here for a screening exam, you're able to manage the NEET PG and the INI questions. Be very, very proud of yourself. All right. Then we are talking about a question which is making a mention of patient presenting with nephrolithiasis and a neck mass. The patient also had his father dying because of pancreatic cancer. Now, this was one question which was applied. I mean, if you're thinking in terms of a patient who's going to be having kidney stones, one of the commonest stones that is going to be seen in the patients is going to be the calcium oxalate stones, right? So patients are going to be having calcium oxalate stones. And one of the reasons why the patients are going to be having calcium oxalate stones is because of elevated levels of PTH. I mean, idiopathic hypercalciuria is what we are aware of as a cause, but PTH problems can be causing this. So what I'm trying to bring down into a summary is that patient is having kidney stones. That means I can be suspecting that he could be having a parathyroid problem. I think this is very easily decodable by for all of you. Then the question is making a mention of neck mass as well. So if my patient is going to be having a parathyroid issue, he could be having a neck mass as well. This patient is also having a history that his father has died of pancreatic cancer. That means familial history of involvement of the pancreas. Something strikes your mind? 3P, pituitary, parathyroid, pancreas. So when you read about parathyroid and pancreas, your brain gets activated. You think in terms of pituitary, and therefore I would be constrained, or I would be rather delighted to be thinking in terms of the 3P syndrome, which is the patient is going to be likely to be suffering from a condition that is given the name of the MEN1 syndrome. So which of the following genes is likely to be associated in these patients? The patients are likely to be suffering from a condition that is given the name of involvement of the MEN1 gene. Pituitary, parathyroid, pancreas. Please look at the other options. Very, very important. Rett gene is going to be ruled out because this would be a patient who would be having the presence of medullary thyroid cancer. The patients over here are also going to be having the presence of Pheochromocytoma, right? And the patients can be having in MEN2A syndrome involvement of parathyroid. So some of you may be asking me the question, sir, isme kyun nahi hum soch rahe? Because in case of Rett problem, you would not suspecting pancreatic cancer. So that doesn't fit in, right? If I'm talking about MEN2B syndrome, so that would be medullary thyroid cancer, Pheochromocytoma, and remember, Marfanoid habitus, mucosal neuromas, and having the presence of megacolon, that is not fitting in. If I'm talking about VHL, VHL is going to be a triad that is going to be seen. So patients would be having kidney cancer. NEET PG question, which one? Clear cell. You remember the fact? The patients are going to be having high risk of development of pheochromocytoma. And these patients are also going to be having the CNS tumor, which is given the name of cerebellar hemangioblastoma. So it was a classical 3P problem, but VHL cannot be fitting in the diagnosis. Of course, it's a separate important question. That's why I discussed. P53 cannot be answered over here. P53 is the commonest gene that is likely to be mutated in 50% of human cancers. But if there is a familial problem with P53, then my patient is going to be suffering from a condition that is given the name of Lee-Fraumeni syndrome. Lee-Fraumeni syndrome. Remember that thing that we talked about, the B cancers, the blood cancer, brain cancer, bone cancer. That is what is going to be seen in a patient having Lee-Fraumeni syndrome, right? So these three are not fitting in. And therefore, the only thing which fits in logically and going by the matching over here, applying your neurons over there, that's going to be MEN1 gene, right? So that is what we just wanted to have an idea, and this is exactly what we had made a mention of in our discussion of the MEN1 syndrome. Of course, we usually start off with something like MEN1 is called as Werner syndrome, not to be confused with Werner syndrome. That was premature aging, DNA helicase defect. Again, a potential question that you just need to keep in your mind from the perspective of the exam questions, right? So this was a discussion of the questions, friends, and as you understand, we had a discussion of around 33, 34 questions. There were a couple of questions that would have been covered in biochemistry, as what we have talked about, let us say, with respect to the inheritance patterns and with respect to other stuff. But all in all, what you find is that except for two questions, one in which the translocation of anaplastic lymphoma was asked you, I repeat the answer, translocation 2.5, and the other question which was making a mention of the fact that the patients were having an applied information over here, like the last one that you had to look at. I mean, beyond these two questions, I don't think that you were, trapped in any of those questions. So the humble request is that whenever you're going to be attending the live classes, I mean, irrespective of whatever your source is, my humble request is, my aim is that you crack the exam with as many marks as possible, right? So please ensure the fact that you are watching the videos very carefully with a proper, still, calm mind so that you're able to grasp the concept. Whenever you're attending the live classes, whenever you're attending the mission classes, please understand the clinical pictures or the scenarios that we discuss with you so that when such scenarios appear in your exam, right, you are immediately having an idea about, this is what I am thinking in terms of this can be the possible answer. Please do attend the live sessions for the simple reason that normally we do not restrict ourselves for having a discussion of only one subject. The moment I feel that my students are, confident and I can have the liberty of asking them questions from beyond this particular subject, we do keep on doing that particular thing, which enhances your confidence so that you can appear in the exam more comfortably, and it enhances my confidence, that my boys and girls are going to be doing it pretty well in the exams, right? No matter whatever the result is, which in all probability, keeping my fingers crossed, is going to be excellent for majority of you. We always are going to be there for you. In case you feel there is any issue at level of any questions or in your preparation, you are most welcome to contact us any which way, right? Stay calm, stay happy, feel confident and good about the fact that you did fairly amazing. We never expected you to have a 100% score. Even if there were a couple of questions which were incorrectly marked by you, this is what I would like to tell you. Our friendship is still going to be there, right? So stay blessed. Do take very good care of your health till the time we catch up in the subsequent session again. Best wishes.